I'm Kelly Knupp. I'm a pediatric epileptologist at the University of Colorado. I'm a professor of pediatrics and neurology, and I see patients at Children's Hospital Colorado. At Children's Hospital Colorado, I'm the director of the Dravet program as well as the lead of the epilepsy team. So Dravet syndrome is a rare genetic epilepsy. We see it in about 1 in 15,000 live births. It usually presents in the first year of life with prolonged seizures, often in the setting of fever or recent vaccines. We can also see prolonged seizures in the setting of temperature changes, such as getting in and out of a bathtub, being out playing on a hot afternoon, walking in and out of a big box store that has heat at the front doors on a cold day when you walk through that heat blast at the front of the store. These children then go on to have other seizure types, usually in the second year of life, and they can have lots of different seizure types. In the first couple years of life, we continue to see these very prolonged seizures that can last sometimes hours in duration and often don't respond well to rescue medications. After the first 4 or 5 years of life, we start to see shorter seizures, but they may occur in clusters. And then they gradually shift to be more nighttime seizures, although some patients do continue to have seizures during the day. One of the characteristic seizures we see with these patients with Dravet syndrome is something called a hemiclonic seizure. Often we see that in the first 1 or 2 years of life. And this is a prolonged seizure that has shaking on both sides of the body, but one side has more shaking than the other side of the body. And sometimes that can be misinterpreted as a focal seizure. It's really important to try and figure out this diagnosis because some of our typical medications that we would use for focal seizures can actually make these seizures worse. So sodium channel blockers like oxcarbazepine, carbamazepine, lamotrigine, which we might use in a focal seizure, make seizures worse in these patients. The vast majority of patients with Dravet syndrome have an underlying genetic disorder with a pathogenic variant in SCN1A. Not all of our patients, there's a small percentage of patients who clinically seem to have Dravet syndrome, and we're not able to identify the genetic etiology underlying it. But the vast majority, greater than 85%, have a pathogenic variant in this gene. The most important thing is to actually think about it and send the genetic testing. The genetic testing is pretty straightforward, and it's available on epilepsy gene panels. It can be done as a single gene test. We don't do that very often anymore because we have lots of genetic epilepsies, and so and sometimes they can overlap a little bit. And so we often send a gene panel. We generally recommend sending genetic testing if somebody has had 2 prolonged seizures in the setting of fever, or if they've had a hemiclonic seizure, because it can be somewhat characteristic for this disorder. So really the most important thing is to think about the testing and actually send it. An early diagnosis is important because of the medication choices that we may make in these patients. And we have data that the longer a child is on inappropriate medications, the worse cognitive outcome they have. So it's really important to make this diagnosis early. And even more important now that we have gene therapies that are in trials so that we can identify children at young ages and perhaps direct them into those clinical trials if families are interested. So the vast majority of these patients are on anti-seizure medications, and there's some that are very specific for Dravet syndrome, such as stiripentol and fenfluramine. It's also, as I already mentioned, it's really important to avoid medications that may make things worse. There are other typical seizure medications that we will use, such as clobazam, valproic acid, zonegran, ketogenic diet. Some patients do respond to vagus nerve stimulation. Many of these patients require a lot of medications to try and have the best balance of seizure control and quality of life. It is unusual for patients with Dravet syndrome to be seizure-free, although we do have a handful of patients who are seizure-free with medication. And so that's always what our goal is, but we always want to pay careful attention to quality of life as well, and making sure that we're not creating too many side effects with some of our medications that are available. This is a very exciting product that's in trials. All of our treatment at this point in time is managing seizures and managing comorbidities in Dravet syndrome. And this is one of the first therapies that is in trials that actually is addressing the underlying disorder in patients with Dravet syndrome, which is the pathogenic variant in SCN1A. So the proposed mechanism of this is that it upregulates the amount of SCN1A that is transcribed into protein, and therefore increasing the amount of sodium channel that's presented in the cell. And we're really excited about this because our hope is that this won't treat just seizures, but treat many of the underlying comorbidities that we see in Dravet syndrome as well. So, this product has already been through safety trials, and is now moving into phase 3 trials. So this will actually be one of the longest trials for patients who are being randomized, because they will be randomized for a full year. Patients who are randomized to treatment will receive 2 doses of 70 milligrams of the medication, followed by 2 doses of 45 milligrams. And those follow-up doses are administered every 4 months. The other patients who are randomized to placebo will unfortunately not receive treatment during this time period, but once they've completed this randomized trial, as long as they qualify, they'll be able to move into the open access portion of the treatment where they actually will receive treatment. The medication is administered in the spinal fluid. So patients will undergo anesthesia. They will have a lumbar puncture so that we can access spinal fluid. Spinal fluid is always tested at the time of drug administration. And then the drug is administered under anesthesia. And then the patients will continue through this trial, maintaining seizure counts as well as undergoing measures of cognitive and behavior and motor function throughout the time period of the trial. The primary endpoint is seizure reduction. It's a relatively straightforward thing for us to measure in clinical trials related to seizures. So that's the primary endpoint, but a key secondary endpoint is cognitive outcome as well. And so, we're really excited to see both of these as endpoints in this trial. While the primary symptom of Dravet syndrome is seizures, there's lots of comorbidities that our patients experience, including a progressive gait abnormality, intellectual impairment, behavioral issues, as well as a number of our patients who have chewing and swallowing difficulties. They may require a G tube for that. We also see sleep issues and behavior issues. So there are a number of comorbidities that we see that go along with Dravet syndrome that can impact quality of life just as much, if not more, than seizures can for some of our patients. And that's one of the most exciting things about this product, is that our hope is that it may actually address all of these comorbidities, not just seizures.